Welcome to the PCA Deep Dive. This is where we move beyond headlines and sound bites to examine the research shaping real-world care decisions. Low back pain is the leading cause of disability worldwide, yet most care models continue to prioritize short-term symptom suppression rather than preventing long-term disability. The real challenge is not whether pain can be reduced today, but whether function can be preserved tomorrow. Today's episode examines a major randomized clinical trial published in the Journal of the American Medical Association that followed patients at high risk of chronic low back disability for a full year. The PACBACK trial compared guideline-based medical care with conservative, nonpharmacologic approaches delivered by chiropractic physicians, including spinal manipulation and clinician-supported biopsychosocial self-management. What makes this study different is what it chose to measure. Not just pain, but disability. Not just short-term relief, but long-term function. In this deep dive, we walk through what the study actually found, why pain masking alone fails to change long-term outcomes, and how integrated conservative care, led by chiropractic physicians, plays a critical role in reducing disability, medication reliance, and future escalation of care. Let's dive in.
If you're one of the, millions of people who've ever woken up with that sharp, seizing pain in your lower back, you know it's just miserable.
Oh, absolutely.
But what you might not know is the sheer scale of the problem. Low back pain, or LBP, is the #1 cause of disability globally.
Yeah.
It's relentless, it's expensive, and it derails lives.
It really is a defining public health challenge. And for clinicians, for patients, the real mission, the high-stakes mission, isn't just getting rid of the ache today.
Right.
It's figuring out how to stop an acute flare-up from becoming a chronic, life-altering disability that just goes on for years.
And that is the exact mission for the massive study we are diving into today. The PACBACK randomized clinical trial.
Yeah.
This was a hugely ambitious project looking specifically at long-term outcomes for patients who are at high risk of their back pain becoming chronic.
Exactly. This wasn't a small sample size. We're talking 1,000 participants. And the goal was to see which first-line treatments could fundamentally change that long-term disability path over a full year.
So they tested 4 different approaches.
Yep, 4 very different approaches to see what actually works for prevention. They set up 4 groups. The first was spinal manipulation therapy, or SMT.
Okay, so classic hands-on care.
Right, delivered by chiropractors or physical therapists. Then you had clinician-supported biopsychosocial self-management. We'll just call that SSM.
The mind, body, and lifestyle approach.
You got it. The third group was a combination. They got both SMT and SSM. And the fourth group was guideline-based medical care, or MC, which is, your standard NSAIDs or muscle relaxants.
And the most critical piece here, the thing we really have to anchor ourselves to, is that they track 2 fundamentally different things.
Yeah, this is key.
They track pain intensity. So how bad does it hurt, 1 to 10, and disability. Disability is more about, can you dress yourself? Can you lift groceries? Can you even sit comfortably? That difference right there between feeling pain and being functionally disabled, that's the whole game.
That's where the real insight is.
Okay, let's unpack these results. We've got 4 different approaches competing to prevent long-term disability over a whole year. What did the PACBACK trial find? Give us the immediate shocker.
Well, the shocker is that for raw symptom relief, the how bad is the pain score, there was basically a null finding.
The null finding.
Yeah, over the entire 12-month period, there was no statistically significant difference in pain reduction between any of the 4 groups. They all performed pretty much the same.
Hang on. So you're saying whether you took a pill, got a spinal manipulation, or did self-management, your average pain level after a year was roughly the same.
That's right. If your only metric is that raw pain score, they all look equally effective or, equally limited in the long run.
Wow.
But here's where the story completely changes. And this reveals what's really driving chronicity, the disability scores. When they looked at the average disability score over that full year, the SSM group and the combined SMT plus SSM group,
Yes.
they showed significantly lower disability compared to the medical care group.
So the mind-body approach and the combined one, they were the clear winners in actually protecting a person's function.
A clear win. The mean disability score difference, it was about -1.2 points for the SSM groups compared to standard medical care.
And for anyone listening, that number, -1.2, it sounds so clinical. What does that actually mean in a patient's life?
It sounds small on paper, but it is a profoundly important clinical difference. It's often the difference between, say, being able to manage your household chores versus missing work, or feeling like you can't go out with friends because of the physical barriers. It's the difference between feeling like a patient and feeling, well, functional again.
So SSM wasn't just turning down the volume on the pain signal.
Not at all. It was giving patients their lives back.
And if that wasn't clear enough, the responder data makes it just undeniable. You have to look at the proportion of patients who hit that gold standard, right? A major 50% or greater reduction in disability.
That 50% mark, that's what we define as a true success in functional recovery. And the supported self-management group, SSM alone, had the highest proportion of people hitting that target, a remarkable 67%.
67%. Okay, now compare that to the others.
Well, the medical care group and the SMT alone group, they were both stuck down at 54% each.
That's a 13 percentage point jump for SSM. I mean, in public health terms, that is massive.
It is, and it delivers a really critical, maybe surprising conclusion about spinal manipulation therapy. Look, SMT is competent. It's a great non-drug way to get some initial pain relief, and it works just as well as medication for those early symptoms.
Right.
But when you deliver it in isolation as a standalone treatment, it just hits a clinical ceiling. It can only take you so far in preventing long-term disability.
That's a great way to put it. It's like the difference between putting out the fire versus creating a fire prevention plan. SMT puts out the immediate flame, but it doesn't give the patient the tools to prevent future fires.
Perfect analogy. And that's why it fails to move the needle on long-term disability compared to SSM. The value of hands-on care isn't gone, it's just redefined. The trial suggests it's best used as an effective entry point.
A way to get the pain down enough so the real work can start.
Exactly. So the patient can actually engage with the broader skill-based strategies they need for true long-term functional recovery.
Okay, so if supported self-management was the clear winner here, we need to spend some real time on what it actually is, because self-management can sound a little generic, like something from a brochure. But this was obviously a very structured, very strategic approach.
It is highly strategic. It's founded on the biopsychosocial model, or BPS. This is that fundamental philosophical shift we were talking about. Instead of treating pain purely as a structural injury, a tissue problem that needs a pill or a passive fix, BPS treats it as a dynamic system.
Meaning it's not just about the back itself.
Right. It acknowledges that chronic pain is driven not just by biology, but crucially, by psychological factors and social context. SSM was specifically designed to target all those drivers of chronicity.
And this wasn't just talk therapy. The clinicians, physical therapists, chiropractors, they delivered this in, 4 to 8 structured sessions?
Right.
How did they translate that BPS theory into practical skills?
So they started with a needs assessment, moving way beyond just the physical exam. They used this visual tool called the Wellbeing Wheel to systematically check in with the patient across 3 domains.
The 3 domains being?
The physical, movement, exercise, posture. The psychological stress, coping mechanisms, mind-body skills. And critically, the social domain, communication strategies, scheduling activities, and just navigating work or family life while you're managing pain.
That immediately changes the conversation from what's wrong with my disc to what is the full picture of my life that's contributing to this pain.
Precisely. And from there, they moved straight into skill acquisition. The whole SSM approach was informed by behavior change science, targeting 3 key things: capability, motivation, and opportunity.
And capability was boosted by, I think, maybe the most important part of this whole thing, pain physiology education.
Absolutely crucial.
The classic what is pain education.
Yeah.
Why is explaining pain so powerful that it can actually change disability outcomes a year later?
Because it demystifies the entire experience. So many chronic pain sufferers believe that pain equals damage. Every little twinge means they're breaking down, which leads directly to fear.
Of course.
This education reframes pain as a protective output from the nervous system, not necessarily a direct measure of tissue harm. Once you understand that pain is often driven by sensitivity, not just injury, you start to reclaim a sense of control.
And that control is essential for fighting those psychological drivers, right? The fear of movement, kinesiophobia, and pain catastrophizing, those are the silent villains.
They are the engine of chronicity. If I believe moving will paralyze me, I stop moving. The disability cycle just accelerates from there.
So how did the BPS approach target those fears directly?
Well, for one, they taught cognitive behavioral strategies. So if a patient is catastrophizing, thinking, I'm going to be bedridden forever, The clinician helps them restructure that thought. They challenge it with evidence and replace it with something active and functional, like my back is strong and this minor discomfort means I'm safely building resilience.
What about the more practical psychological tools? You mentioned things like breathing and guided imagery. How did they use those?
They're integrated directly to downregulate the stress response, which is so tightly linked to pain sensitivity. Simple techniques like relaxed breathing. They train the patient to consciously lower their sympathetic nervous system activity.
It's not magic, it's a physiological skill.
It is a skill. When you reduce that stress and muscle tension, you increase the nervous system's capacity to tolerate movement. These skills build self-efficacy. They make the patient feel capable of handling a flare-up without immediately resorting to fear or pills.
And that's the real long-term payoff. The skills are portable, they're durable, and they reduce that reliance on external fixes. Which brings us right back to the stark comparison between this active SSM model and the standard medical care approach.
That contrast is really the headline finding of the whole trial. The medical care group relied heavily on pharmacology NSAIDs, muscle relaxants, and these drugs are masters of short-term symptom suppression. They interrupt the pain signal.
But it's a passive approach.
Totally passive. A temporary fix that does nothing to change the patient's underlying functional patterns or their psychological relationship with pain.
And that's why it failed.
Exactly. It's why medical care was statistically inferior to SSM in reducing disability over the long term. This reliance on just masking symptoms, it often traps patients in a cycle where they might need an escalation of care, later injections, surgery, because the core issues were never addressed by a pill.
And whenever we talk about pills, we have to talk about safety. The conservative care models weren't just more effective, they were also far, far safer.
That risk-reward comparison is so important for people to understand. The conservative care groups, SMT and SSM, had an exceptionally strong safety profile. Adverse events were almost all minor musculoskeletal soreness, the kind you get after starting a new workout.
But the medical care group, they had a serious systemic event.
They did. One person in the medical care group experienced a serious adverse event involving a life-threatening increase in blood pressure, and it was directly attributed to the prescribed medication. That is a profound distinction. On one side, you have temporary muscle soreness from learning to move again. On the other, a life-threatening systemic event that's just inherent to the intervention. It's a huge validation for a conservative care-first model.
And on top of that, the success of SSM wasn't just better for the patient's body. It was better for their wallet and for the healthcare system.
Absolutely. The SSM groups not only had better physical function and less fatigue, but critically, they reported using fewer medications and less healthcare overall for their back pain throughout the whole year.
Self-management equals self-reliance.
Which means less reliance on expensive and potentially risky medical interventions down the road.
So, if the winning model requires seamlessly integrating hands-on care, supervised exercise, and this BPS education, who is actually best positioned to lead that charge?
Well, the study's design points right to the providers of conservative care. We saw that SMT alone hits a ceiling, but chiropractors and physical therapists are uniquely trained to integrate all of these components.
Right.
They can provide the immediate pain relief of manual therapy and deliver the necessary patient education and therapeutic exercise, all within a single clinical relationship.
That's a huge point because it reduces fragmentation. The patient isn't getting a pill from their GP, a manual fix from a specialist, and a behavioral leaflet from someone else. It's one continuous integrated pathway.
Exactly. The lesson here isn't to abandon hands-on care, but to evolve how we deliver it. The goal is to maximize function and minimize disability, and PACBACK shows the most effective way to do that is by combining that passive relief with active, patient-empowering BPS skill acquisition.
What a powerful deep dive. I think the central takeaway for you, the listeners, just crystal clear. If you are at risk of chronic disability from low back pain, achieving long-term recovery means moving past passive symptom suppression. You have to move beyond just relying on medication or even manual therapy by itself, and actively engage with an integrated skill-based approach like supported self-management. The fix is active, not passive.
And that leads to a final sort of provocative thought. The PACBACK trial demonstrates that the best fix isn't a drug or a procedure, but it's empowering the patient with skills and knowledge to address things like kinesiophobia. So if this shift from a purely biological symptom focus to a comprehensive BPS model is so effective for back pain, what could happen if we prioritize building patient self-efficacy over just temporary symptom suppression for them too? It really redefines what success looks like in managing chronic health.
Thank you for listening to the PCA Deep Dive. As we close, the key message from this study is clear. Pain relief and recovery are not the same thing. Approaches that focus solely on suppressing symptoms may reduce discomfort in the short term, but they do little to address the underlying drivers of disability or protect patients from long-term functional decline. The PACBACK trial demonstrates that conservative, skill-based care changes that trajectory. When hands-on treatment is combined with supervised movement, education, and biopsychosocial self-management, patients experience better function, less disability, reduced reliance on medication, and lower overall healthcare utilization over time. Spinal manipulation plays an important role as an entry point. It helps reduce pain and restore confidence early. But the strongest outcomes occur when that care is integrated with active strategies that build resilience, self-efficacy, and long-term capacity, an approach chiropractic physicians are uniquely positioned to lead. At PCA Deep Dive, we rely on independent, peer-reviewed research to bring you the most current evidence available. The Pennsylvania Chiropractic Association does not generate this data. Our role is to examine published studies and help translate their real-world implications for patients, clinicians, and decision-makers. If you found this episode valuable, please take a moment to rate, review, follow, and share PCA Deep Dive. Your support helps us continue delivering evidence-informed discussions that elevate patient-centered conservative care. This episode and all PCA Deep Dive content is a service of the Pennsylvania Chiropractic Association, advancing evidence-informed, function-first care across the Commonwealth. Stay curious, stay engaged, and we'll see you in the next Deep Dive.